Hi, welcome to Two Guys in Scrubs. We are Two Guys in Scrubs. I'm Silas Rades.
And I'm Delbert. We are second year medical students at the University of British Columbia, and we started this podcast to share what it's like going through medical school, discuss medicine, and pretty much anything else.
Please be advised, Two Guys in Scrubs is for educational and entertainment purposes only, and the views expressed do not reflect the views of our program or supervisors.
Right. So for the inaugural episode, I guess we don't really have a plan. I guess that's going to be the theme going forward to some extent.
Yeah, I think it's a good theme because it keeps it exciting.
Oh, yeah.
I think we should really be trying to keep our audience who doesn't exist on their proverbial toes, of which they don't have any, except, I guess, in my imagination. Anyway, so moving on. Delbert, as you are one of the guys in a scrub, have you ever been in said scrub?
Yeah, unfortunately, yes. I don't think scrubs are particularly comfortable.
Take me back to your first time putting on scrubs.
Oh, I'm wearing scrubs right now, actually.
Are you good?
Yeah. But the first time, yeah, probably because, well, I don't think they're particularly comfortable, but they're very functional. So I like wearing them at home, and I wear them like pajamas.
I must say that that was very surprising.
Really?
But in a nice way.
I wear scrubs pretty much 24/7.
So when I was coming up with this name for this podcast, I thought it would just be a cute little name, but little did I know that Delbert Yip in the flesh wears scrubs all the time.
Yeah. For better or
I
worse.
actually heard that some of them can be very comfortable. Like some of them are, borderline look like Lululemon type things. It's quite nice.
Yeah, no, I just wear hospital scrubs.
Well, I believe the first time that I put on scrubs ever was maybe like last year when I was shadowing my first surgery. Mm-hmm. And I was in the operating room with an orthopedic surgeon doing a few total knee replacements. And that was the first time that I wore scrubs.
Were they comfortable?
They were okay. I find the pants often, it's hard to get the waist right. They're like falling down, for example.
Because you have the drawstring, right?
Exactly. And, the quality of these hospital scrubs are questionable. I think the majority of them are probably from like 1976. And definitely no elasticity left in there. But funny enough, one of our colleagues told me that they were in the OR and they were wearing the infamous scrubs. And they were, I believe they were assisting with a thyroid surgery. It might have been a total thyroidectomy, which of course is, removing the thyroid gland. And they, being a medical student, they're not allowed to do much, but they were allowed to hold the, well, I'm blanking on the word. What is the tool that you can use to hold tissue open, to hold the incision open?
Retractors?
Yeah, but less mechanical, more just like manual, like looks like a fork or like a scrape.
Oh, I have no idea.
Yeah. Like imagine if you take like, those back scratchers they used to sell, like a long stick with a little rake like end to it.
Yeah.
They kind of look like those, and you can kind of just hold the incision open. Anyway, back to rambling now. Our colleague was holding those open, so both of his hands were occupied, and his scrub pants proceeded to fall down. Fall down around his ankle, but I think that he was gowned up so that no one could see. But yeah, the pants fell down. He had to like stay like that for, I don't know, 20, 30 minutes. Anyway, so all that is to say, quality of the scrubs could be improved.
At least, I mean, that's not a problem for me because I just wear them at home.
Well, that's how you really. I'm imagining at home you're just really living. You're really living the life. It's kind of a fake it till you make it situation.
Yeah. Well, I'm pretty much 100% sedentary, so gravity is not an enemy, or I'm not opposing gravity.
But anyways, I guess maybe a little bit about us, since this is the like you said, the inaugural episode. We just started our second year at UBC. We're about 1 month in,
Hmm.
and yeah, I was really curious to ask you just about how it's going. But first, something for me would be that interesting. I ran into some first years yesterday, I believe, and just while talking to them, it made me feel like we're only starting our second year, but I already feel so old, so to speak, or like I feel like we've been in the program for 5 years. The
Yeah,
way that interacting with the first year. So it just goes to say, like, I think in our program we get introduced to so much so quickly that already by second year you kind of feel like you're in residency in some way.
I'm sure
Do you
that
know what I mean? Or
only
is that
yeah.
just me?
No. Yeah, I'm sure it just keeps compounding, right? This effect of like that you're in some sort of hyperbolic time chamber. That every year that passes, you age probably 5, 10 years.
And interesting, I believe if you look at the epidemiological data on physician lifespan, they would agree
Hmm.
with the hyperbolic time. What did you say?
Hyperbolic time chamber.
Hyperbolic time chamber, yes. Especially certain disciplines of which we will not name. Actually, change my mind. Let's name them. What are
Emergency.
the Yeah.
Absolutely. Remember last year we had that lecturer who was, always caffeinated and um he gave our physiology lectures.
Hmm.
Yeah. I remember one time right before this is when we were still attending lectures, which we can talk about some other time. Um I looked up the average lifespan for different specialties, and it turns out emergency physicians had a average lifespan of like, I don't know, was it 60, 70 years, which is below the average for the general population, not to mention physicians.
It certainly is, and I suppose being in such close proximity to life-saving help is not quite enough.
Ironically.
Ironically, yes. I didn't mean to be too cynical, of course. Nothing but love to all the emergency physicians out there. Um, for the record, we're not having fun at your expense. Just talking about statistics, of course.
Yes. I think it's a field that attracts um, people who enjoy that fast paced, dynamic lifestyle, right? Lots of things going on.
Hmm. And yeah, I've talked to a few people that I know that have ADHD, which is a topic that we've discussed recently
Hmm.
in terms of the curriculum we're learning. But interestingly, I know the friends that I have with ADHD, that aspect of the job is extremely important to them. They find that if they're not in an environment that is constantly stimulating them, it's very, very difficult for them to do their job, even sometimes with medication. So I'm not saying all emergency doctors have ADHD, but there's definitely there's definitely certain personalities and certain psychological phenotypes, whether it be a diagnosis or not, that really thrive in that kind of environment. I can't say it's for me, but I do understand it.
Yeah, on that note, even if they did have ADHD, if they were not diagnosed as a child, in order to be diagnosed, one of the criteria is that there has to be some form of like significant impairment, right? And I feel like at the point, if you are at the point of, being a physician and saving other people's lives, it'd be hard to argue that you are impaired to that degree.
Totally, totally. And it also makes me think about what proportion of the adult population are living with ADHD and have never been and are just not diagnosed,
Hmm.
and maybe out of stroke of luck or just as a matter of gravitating towards things that interest them, their environment alone is kind of able to mask the underlying disease process. I don't know.
Yeah,
Calling ADHD a disease is kind of weird, although we kind of categorize all these things as disease states of some kind.
you could say it's a normal variant, right? Some people like that term more.
Oh yeah, or neurodivergent, I guess, is
Yes,
a
yes.
permutation on the theme, which I do understand. That actually brings us to another tangent. Even though we were supposed to be talking about second year, I believe tangents is something that we both really enjoy. So here's another one. Um, in terms of communicating medical knowledge to the public, I do understand when we're talking about the changing of terms, or we don't want to define everything as a disease, for example. Something that's been top of mind for me recently is the ways in which the medical community at large communicates with the public. We know that we often do a very poor job, um, and I think recent surveys kind of show that people are disappointed in the medical information that they receive, and if they're not disappointed, they're a lot of the time just confused. Um,
Mm.
but Yeah, have you ever thought about ways in which the medical community could do better in terms of communicating to the general public, or maybe even not even as productive as doing it better? But have you ever thought about ways in which we do a very poor job?
Well, to me, the general public, because I live in Richmond, is primarily non-English speaking, right? So when I think of communicating knowledge or just any specialized medical information to the population that I live around, one is translation, and then the second part, of course, is making it accessible, which is the universal component, right? Regardless of language or culture. Um, I think one thing that Richmond Hospital has done very well is to just put signs up in all different languages, well, primarily Chinese, and I know there are also like liaisons, I think they're called, or people that they can bring in to help in real time interpret for patients between their entire healthcare team. So I think that's more sort of on the ground, but I guess you're talking more about large public health scale campaigns.
Well, it doesn't have to be. It could be like a micro or macro question. I think, well, something that comes up to me when you speak about language and language translation. Of course, we live in Canada, where the number of languages that are spoken are is very vast. And something I listened to an interesting talk recently about health literacy, kind of
Hmm.
trying to quantify this variable that they call health literacy through the Canadian population, and something that they have quantified through surveys. They get people to sign up, I don't know how, and they send them. It's essentially an exam where people have to answer multiple choice
Mm.
questions, and at the end they kind of get a health literacy rating.
Yep.
But when we talk about health literacy, you can think about how important language is, and for the amount of Canadians that which English is their second, third, fourth, fifth language, or whatever it may be. We can say that maybe their health literacy lags behind, but it's not really a statement on their intellectual or their language capacity. It could just be
Absolutely. Yeah.
it could be an accessibility program, like exactly like you're saying. If you just pick me up and drop me off in China, for example, they would say, "Wow, this guy's Chinese literacy is really bad. Like this guy's health literacy is terrible." I think he's operating at a preschool level or worse. Uh, so I think that accessibility is such a buzzword recently with EDI initiatives and
Sure.
inclusivity and et cetera. But it really is beyond any issues people might take with it kind of being a buzzword in culture. It is really such an important component to address, especially as it connects to health literacy. And interesting fact I'll just smuggle in here that I learned from the talk is that two things that people might find interesting is that studies have shown. I can't judge the quality of the studies, but the average reading level for the average Canadian adult is approximately grade 5 level.
Mm.
Um, so you have to consider that, and also uh, in terms of health literacy, Canada ranks lower than the average globally, if I remember the statistic correct from the talk. So when we think about medicine and think about doing our job and our service to our patients, if we're failing in our communication, um, then we can't expect to have excellent health outcomes for patients.
That's true. And, that, I guess, makes me think about the difference between making something more accessible versus the potential risk of patronizing or infantilizing
Hmm.
people, right?
Hmm.
And part of that comes down to bedside manner, I think. Like, how do you show respect and maintain somebody's dignity, even if they may be, say, on the border of dementia or do not speak English very well? Um, when we were, when we're doing neural clin skills, this is where that comes up a lot, right? Because we're talking about mental status examinations, or if we're thinking about examining children, we have to use different methods. But I feel like we can use the same principles that we apply to those special populations to the populations that we're talking about right now, right? So just adapting our approach, I think, can make a big difference. But doing that alone does not completely mitigate those risks of, um, infantilization or whatnot.
I totally agree, and yeah, that's a great point. And I think we should kind of I'll just round off this tangent with saying how everybody loves talking about AI recently, but it is exciting to think about the ways in which AI assistants can kind of make up for lost ground, or ways in which the physician or the medical system is unable to reach the patient, such as being available for them 24/7. I don't know how many people are already getting their medical advice from ChatGPT and other platforms, but I would imagine it's quite large. And I think as these even chatbot type technologies become normalized within the medical system, they may help to bridge this gap. Or in the next few years, AI is just going to have an explosion, and we are going to be soon just subservient to our robot overlords, which might be likely as well.
I mean, I don't know if you've seen stories of people who, you could almost say it's like a dystopian um, fiction that somebody came up with, but like some people with underlying psychiatric instabilities, if that's the right word for it. So maybe undiagnosed schizophrenia that was later suspected after whatever happened, they get mired in these conversations with AI. And because AI is designed to almost basically give you what you want, right? It's like an echo chamber that exacerbates a lot of your own biases, right? And we know that in psychiatry, one of the most effective treatments is actually cognitive behavioral therapy, which does the opposite of that. So a human therapist, of course, is trying to get you to recognize your biases or preconceptions, beliefs, and challenge them. And over time, through many sessions, you learn to either, cope, I guess. Maybe that's not the right word, but you learn to work around those ways of thinking.
Yeah, that's extremely fascinating, and yeah, it just reminds me. I mean, I use ChatGPT myself sometimes for studying. Not so much anymore to look up questions, because we have better services like open access. What's it called again? Why am I just blanking? I use it all the time. Open evidence.
Open
Thank
evidence,
you.
yeah.
To be able to look up factual information quickly, but I still like to use voice mode on ChatGPT and kind of work through clinical cases and have it just as a clinical instructing assistant, for example. But I constantly have to remind it and instruct it to stop stroking my ego and give me some constructive criticism, because I know it'll say, "Wow, that was a fantastic answer," and I say, like, "Okay, can you actually give me a critical answer?" And it's like, "Actually, you missed this," and I was like, "Okay, well."
Yep.
So but I understand, even from a profit motive perspective, how having these adversarial AIs is going to push people away from the product, and I imagine that's something that the companies are very wary of. Yeah, as we moving us along, I know some other things we wanted to talk about were potentially, is there any areas of research or new research that you wanted to bring up, or that you found interesting recently, or we can also share our favorite mnemonic of the week. Considering mnemonics are medical students' life force, and that we may wither away and die without them.
Yeah, I mean, I haven't read anything too in depth recently, but let me think. It was a paper about. Let me try and quickly find it. Oh, here we go. So the title is Hospital EHRs, so electronic health records, reveal hidden drug-driven hyperglycemia. So basically what they did was they took EMR data or EHR data from, I think, tens of thousands of patient visits at Cedars-Sinai Hospital, which is a major hospital in the States. And they analyzed the drugs that these patients were given while they were in hospital and their effect on blood glucose. And they identified several drugs or supplements, I guess some of them might be considered, that raised blood glucose or were at least associated with higher blood glucose higher blood glucose that we normally don't associate with that effect. So some of these include magnesium oxide, right? So magnesium oxide we think of in terms of a what's it called? It's like a laxative, I think. Is that right? And it also
I know that magnesium has laxative properties, but
yeah, magnesium has laxative properties also as a antiarrhythmic for like torsades de pointes, right? And then vitamin D was another one, which is kind of strange because we normally associate vitamin D with, well, bone and calcium homeostasis. And then finally, norepinephrine. Norepinephrine kind of makes sense because we know that sympathetic nervous system does affect, the catecholamines and that sort of thing. But the other two are pretty strange. And then there's a whole bunch of other ones. So the whole, I think the message of this article is that if we can sort of integrate this big data approach to healthcare, we can potentially identify and improve patient management or identify patterns and use that to improve patient management. Of course, it needs to be confirmed. It needs to be functionalized. Like, how does it actually work? What is the effect? Blah, blah, blah. But it's kind of interesting.
How is it? And if you don't know the methods right off the top of the head, that's totally fine. But I'd be interested in this paper how they were confident about the actual causative effect of some of those.
Oh, it's
drugs.
not causative. It's just correlations, and it's they emphasize that it is hypothesis generating rather than
right.
Yeah,
which is interesting. I think people can kind of are too quick to dismiss some of these more thought provoking or hypothesis driven papers. Maybe I'm just saying that because I'm currently trying to finish a very much almost borderline esoteric hypothesis-driven paper. But you will run into people who might say, if it's not if it's not a systematic review full of RCTs, then I don't even want to hear about it. But I think that kind of blindsides you to some of the more interesting evolving aspects within research, and we need people to kind of be thinking outside the box in order to discover new ideas. So it's a balance.
And it's also just more interesting, right? Like, what if in the future is, you would, like, for somebody with diabetes, there might be in the future some sort of warning or contraindication to giving routine vitamin D. I mean, I don't see the link there, but that's because we're not taught that there is a link, but maybe in the future.
Yeah, absolutely. And maybe to pivot to something a lot less interesting in that sense, but by no means not important. I came across today just the American Cardiology Society has updated. Well, it was published in Circulation in April. They have updated their guidelines for the management of ACS, of course, being acute coronary syndromes, which I'm not sure when this terminology was introduced, but for the layperson, this is kind of our category of heart attacks, almost as they're kind of commonly called. So we have reduced blood flow to the heart. Of course, you have structures inside the heart, namely the muscles that rely on blood to function, and if they get deprived of blood, then it can cause a heart attack. And this is kind of the umbrella of what are now known as acute coronary syndromes. So I'll just quickly read this out because it's a little bit dry. and I just want to see your take on any of these kind of key findings or updates in the guidelines, if anything sticks out to you or not. So I just have them written down here. The first was um, they're recommending quite aggressive dual antiplatelet therapy after acute coronary events. And so this is a combination of aspirin, which is a commonly known antiplatelet to everybody, but with another agent. And there's a new agent. I don't know how to pronounce this. Ticagrelor. Ticagrelor. I don't know if you've heard of it. Yeah, ticagrelor, which is a kind of a new antiplatelet agent that I'd never heard about. But that comparing to some of the more traditional clopidogrel. How do you say
Yes,
it?
yes.
Do
I'm
you
not a
say
pharmacist.
do you say clopidogrel? But that's the traditional antiplatelet.
Yeah.
So yeah, just they're reinforcing aggressive dual antiplatelet therapy is superior to platelet monotherapy. Do you want to maybe quickly tell or do you want to quickly explain why you might use antiplatelet therapy after an acute coronary event?
Well, one of the reasons is that after usually most heart attacks are due to myocardial infarctions, which are a usually it's atherosclerosis or thrombosis, meaning some sort of structure, usually a blood clot or fat or whatever, is occluding, that is closing off some of the arteries that supply oxygenated blood to your heart, right? So antiplatelets, anticoagulation medications will help prevent blood clots from forming. And so that is helpful. And then there's not much we can do about fat deposition or like calcium deposits. That's more like in the realm of atherosclerosis, which we would typically treat with like a stent. But majority of blood clot induced myocardial infarction we can often treat with antiplatelets, anticoagulation, and even things just like antihypertensive medications if it's not too serious.
Right, exactly. And it may seem a little bit obvious, but if the formation of these clots are so risky, then why not just give as many antiplatelets as possible?
Yeah.
Like why do we have to be so potentially conservative? Like why is it even a guideline that we have to do dual therapy or give a higher dose?
Yep. So one of the complications, of course, is bleeding. So if somebody already has some bleeding diathesis, we call it, so a tendency to bleed, this could result in catastrophic bleeding. And we're particularly concerned about bleeding in the brain, right? Because one, the brain is one of the most sensitive organs. Two, if we have to do any sort of intervention in the brain, it's going to be very invasive, and there are high complications with that. And then on the other side of things, let's say we give aspirin, right? Aspirin has a fairly narrow therapeutic window, right? And so we can't give too much of it. And then there are also other side effects for other medications. I can't remember them off the top of my head.
Well, exactly, and that was perfectly explained, I think. If we, I just look at some of these other findings, I'm going to skip over two are kind of very procedural and kind of procedures that I'm not very familiar with, but just at a glance, in terms of percutaneous coronary intervention,
which is just stenting, right?
Which is just stenting, or I believe now like you can do. Yeah, it's mostly stenting. I guess in the context of ACS it is, but if you broaden out to valvular issues, for example, then of course we can do other percutaneous procedures like replacing people's valves, etc. But at least for PCI for acute coronary syndrome, the new guidelines is that going through the femoral artery or the femoral approach is much preferable to radial or going through the wrist. So that was kind of interesting, but I don't know enough about the procedure to kind of tell you why it's interesting. But that was cool to see, and also in cardiogenic shock, where the heart is not able to pump enough blood to perfuse the rest of the tissues. There's just this new flow pump, I guess, that they use. That's a reasonable option, but all that kind of stuff seems a bit more for the cardiologist. But one thing I did want to mention, in terms of management, and this would apply even more in the family practice setting, is that something that we've known for some years, which would be whether kind of how conservative should we be with statin therapy? Are these drugs that are meant to lower cholesterol and reduce risk of having an acute coronary event? There's always been, and I don't know the evolution over the past few decades, but extremely aggressive statin therapy, or like really trying to lower LDL to a very small number, has not made it into the official guidelines until very recently. But I know multiple family doctors whose personal approach is to try and lower LDL to a very low level, like well below what the guidelines were in the past. But now, so it was interesting to finally see that some of the smaller studies and now larger studies have been amalgamated into the 2025 guidelines, which is that high intensity statin therapy is now an official recommendation.
Mm-hmm. Yeah, so statins, especially rosuvastatin and so on, are very effective at lowering cholesterol, and they don't have that many side effects. Like if we compare it to their benefit of preventing, for instance, atherosclerosis, right, and subsequent myocardial infarction. So it's very, very useful. And I guess it depends what sort of risk factors you have. Like I remember when I was doing my family medicine rotation last year, my preceptor asked me to calculate the risk for some random patient on the phone, and that was the first time I encountered that calculator, that the algorithm they use to determine who needs statins. And there's several risk factors, like what is your age, of course, what's your lifestyle sort of like, that sort of thing. So maybe I guess they might be lowering the threshold to give more statins. I'm not sure. Of course, lifestyle management. Actually, I don't know. I recall reading over the summer that pharmacotherapy might be first line rather than just trying out lifestyle. Do you remember that?
I don't remember that.
Okay, maybe I'm thinking wrong. I definitely remember some sort of guideline from 2025 suggesting something like lifestyle isn't necessarily the only thing you can do first line. But I don't remember if it was this setting or another setting.
I think you could be right. And I think there's certain things in which, we all kind of have this intuition, not just in medicine, but the general population, that these, having a healthy lifestyle is beneficial to our health, et cetera. And I think with the emergence of more and more lifestyle information online, people can get the sense, at least in terms of some people that I've spoken to, they can kind of over extrapolate the power of lifestyle in certain medical contexts. So we know, of course, that having a healthy lifestyle, not smoking, not drinking, regular physical activity, of which you wouldn't know about, as per your comment at the beginning, and balanced diet, etc. These are thought to increase the lifespan, try to mitigate against disease and chronic disease, et cetera, et cetera.
Yes, do as I say, not as I do.
That's right. But I think, in terms of sometimes modulating a very specific parameter, for example, in this case, someone's LDL levels or LDL cholesterol levels, when you push lifestyle interventions into a narrow corner, sometimes then just the magnitude of the effect is not enough to be protective in certain medical contexts. So that was just something I was thinking about recently because I have a friend who is currently trying to treat a recently diagnosed medical condition through lifestyle interventions only, and one of the things I've been trying to communicate to them is that while these lifestyle factors are important, and it's not that medicine and it's not that doctors are not acknowledging the power of having a healthy lifestyle, it's just within certain disease contexts and within modulating certain biological parameters, just the magnitude of the effect of eating well and exercising and so on could not be enough. And I think that what you're bringing up about LDL cholesterol and this kind of guideline around pharmacotherapy immediately kind of speaks to this concept.
Hmm. Yeah, I can't find
But
the paper, but it was. I'm pretty sure I saw it. It was American College of Cardiology, 2025,
mhm.
something like that. Okay, actually, I found it here. So, okay, it wasn't for statins. Okay, so 2025 American College of Cardiology guidelines recommend semaglutide et al. So these SGLT2 inhibitors as first line over lifestyle changes to lower cardiovascular disease risk in individuals with uh, heart failure with preserved ejection fraction. So that's HIF-PEF, and and of course the other risk factors that these SGLT2 inhibitors are usually prescribed for, namely
Mhm.
diabetes
Ah,
and
fascinating. That
obesity
was
as well.
right, right. Well, there you have it. I
So
think we could
not statins, SGLT2 inhibitors,
not
which
that
we already know
SGLT2s.
are one of the superstars right now of the last 5-10 years, because
I
we're
feel like that's what I was just saying. I feel like every week we learn about the new and magical effect of
yeah.
these drugs.
I think it's mortality benefit. Initially, we thought it was just diabetes, and now it's obesity and metabolic syndrome, hypertension. Yeah.
And I think don't hold your breath. Next week it'll help to bring down your mortgage payments as well. But we could go on a big tangent about those drugs. I think is a very interesting topic, not just in medicine, but also from a social perspective, and kind of
Mm,
how I hear them talked about, kind of outside the medical context. But I think we can leave that aside, at least for this week. And I wanted to share my mnemonic, bringing it
okay.
back,
Yep. Yep.
share my mnemonic for this week, which you may not find terribly interesting, but it's just I am only sharing it today because it came into my mind this morning, and mnemonics are great, and I love the ones that have been made, but I think for myself sometimes I try to make my own little mnemonics, just because
Yes.
I find like when I come up with them myself, it is even a higher chance that I'll remember them. And ironically enough, I have it written down so to kind of prove how well it works. No, I'm kidding. Um, so I was I was just studying a little bit of ophthalmology this morning, and there is this one I guess interesting feature of embryology is that if you look on the back of the posterior aspect of the lens,
Hmm.
you can see this small dot that's physiologically normal, and it's a remnant of the so-called hyaloid vasculature, which was supplying the eye during
Ah,
embryonic
yes.
development. So the hyaloid vasculature regresses at some point
That's the
during
second
development.
pharyngeal arch, right?
Well, I should know because it's going to be on our probably going to be on our exam coming up. But so
Hyaloid or hyoid?
I'm going to say yes. I believe it's hyaloid.
Oh no, maybe it's not. Okay,
Yes, hyaloid. HYA hyaloid. Yeah,
maybe it's not.
they could be the
Never
same
mind.
thing. But anyways, we digress. Um, so we have the hyaloid vasculature. It's supplying the eye structures when you're an embryo, you're developing, and then at some point it regresses and is replaced by the postnatal vasculature as we associate it now. Of course, retinal artery, ophthalmic artery, etc.
Mhm.
And this dot that you can see on the back of the lens is called the Mittendorf dot. So my mnemonic for Mittendorf dot is we have hyaloid and we have Mittendorf. And so for me, it's Snow White. It's hyaloid, hi ho, it's off to work we go, which of course is the seven dwarfs in Snow White, their favorite song. So we have hi ho, hyaloid vasculature, and Mittendorf dot.
Mm,
And that's my mnemonic for today.
great. I,
Try not to. I know you're shaking with excitement, but try to keep it together.
speaking of ophtho, yesterday
Yeah.
when we were after our case study thing, we did a bit of review of the cover uncover and what's the other one called, the alternate cover test, right?
I
So
hope you're about to tell me about it because
okay, so for
I'm on
instance,
the edge of my seat.
when we are trying to identify what type of strabismus someone has, we start with examining the corneal light reflex, right?
You might,
So,
for once again, for our non-existent listeners who don't exist yet, briefly explain what strabismus is.
okay, strabismus is a asymmetric, um, well, what would you call misalignment of the eyes, asymmetric alignment of the eyes. So one eye might be deviated outwards or upwards or whatever direction, whereas the other eye, it could be normal, it could be deviated some other way. There are more complex forms of strabismus or asymmetry, where it's dependent on the direction of gaze, but that is more complex. I think the most common form of strabismus is what we call an esotropia. That's esotropia, which is where one eye is deviated inwards, so it's looking towards the bridge of the nose. Yep.
Mm-hmm.
Okay, so and a corneal light reflex, we shine a light and we see sort of where it reflects off on the eye. And so if somebody's eye is deviated inwards, that light reflex is going to look as if it's been displaced outwards. So it's going to usually be on the white of the eye, or maybe on the iris, but it's not going to be right in the pupil. Normally, it should be right in the pupil. Okay, so
and people can think about, sorry to derail you here, but people can think about this. It's not the same, but when you take a flash photo at night and you see that the red glow in someone's pupil, of course that's not the corneal reflex. That's the red reflex off the retina, if I'm not mistaken. But you can think about it like that. What we're talking about is you can see a circular white spot, which is kind of like it looks like a reflection of light just in the person's pupil, and we're looking to see if those both stay like in the center of the pupil, or if one of them is off. And that's one of the ways you can assess for strabismus. Okay, take it away.
Well, now that you brought up red light reflex, most people probably don't know it nowadays if they've been born in the 2010s, because film has been almost completely phased out of the market. So
that's a good point.
I think a lot of Gen Alpha, Gen Z, they probably have never printed film out unless they have that as a idiosyncratic hobby of theirs. Anyway, okay, so corneal light reflexes are our first step in assessing strabismus. As Silas explained, the white dot is going to be displaced away from the center depending on where, what kind of misalignment you have. So let's say you have a esotropia. So one of the eyes is looking inwards, the white dot is displaced outwards on that eye, but on the other eye, the white dot is in the middle. This is what we call a tropia because it is visible without even at rest, right? So we don't have to do anything to elicit that misalignment. In the cover-uncover test, what we do is we cover one of the eyes and we see what happens to the other eye, and then what happens to the covered eye when we uncover it. Okay, so let's say we have a esotropia of the left eye. That means only the left eye. So the right eye is normal. The corneal reflex is centered in that right eye. And in the left eye, the corneal reflex is displaced laterally because that eye is esotropic. It's looking towards the right. Now,
and of course, so we're on the same page. Oh, it's esotropic. So the left eye in this case is, you can kind of imagine, looking towards the nose.
Mm-hmm. So now let's imagine we cover the right eye. What happens to the left eye?
Well, I believe it depends on the results of the test. Or is this sustained? Is it no matter what? If you have
if it is just a simple esotropia.
I believe if it's a sustained, well, this is a good quiz now, but if I believe it's a sustained esotropia, then nothing should happen.
Okay. And then what if that eye, if the left eye now fixates so that it corrects the tropia? What would we call that?
I do not know.
So that is still atropia. And that is one of the signs of tropia. Um, so basically, what happens when neither of the eyes are covered? So when this person is walking around, every day, their left eye is deviated inwards, but the brain has learned to shut off input or suppress input from that eye. So it's not using that eye very much. It's relying primarily on the normal right eye. So when you cover the right eye, the left eye will fixate by moving laterally, moving towards the left. And now the corneal light reflex in the left eye will be centered, right?
So to make sure I'm following along and put it into simple terms, we have kind of, for various reasons, we don't have to talk about the causes. We have one eye that's kind of looking in towards the nose, and over time, because of this misalignment, the brain kind of starts to rely more heavily on the input from the eye that's looking straight, and so the other eye just kind of gets ignored. And over time, this could potentially exacerbate the problem because you're using less and less of the sensory information from this eye. But when you cover the good eye, you no longer have all that sensory information that you've been relying on. So the only thing left is to kind of wake up the bad eye, so to speak. And this can, in some patients, can cause it to recorrect. Did I understand correct?
Yep, exactly. Now, okay. Now, what if when we remove the cover, the left eye stays corrected? So the corneal the corneal light reflex stays centered in the left eye, and
So the eye is still pointed straight forward. Yep.
Yep. Whereas the right eye now looks esotropic. So
No
it's
way.
reversed.
This can happen. Wow.
Yeah.
Wow.
So what is that?
Yep. Well, you can tell by my genuine surprise that I have no idea.
So this is called an alternating heterotropia or something. Alternating esotropia in this case. I don't know what exactly the mechanism is, but in some cases, when you do the cover-uncover test, the heterotropia, which is the misalignment, will just reverse after you uncover the good eye, quote-unquote good eye. And that, I think, represents the degree of suppression that the brain has done. So it maybe if the originally quote-unquote bad eye was not actually that suppressed, like it still has enough function so that when you remove the cover, the brain is like, okay, I can live with this. You know what I mean? Yeah, so I think that might be the determinant, whether or not it alternates or whether or not after you remove the cover, it reverts back to its original esotropia, left-sided esotropia.
Fascinating. And you would expect this kind of phenomenon. At least my intuition would be that the longer that one has lived with the accommodation, like the brain accommodation, the less of a chance there is of the effect the effect that you mentioned, which would
Perhaps,
be that. Yeah.
Or maybe they're just covering, they're doing the cover-uncover test on their own all the time, and so they're training both eyes.
Oh, that's very interesting. Definitely kind of a lot to wrap your head around when you talk about all the different types of tropias that you could have, and all the different tests to bring them out.
And there's also the phorias too.
Oh yeah, don't forget about the phorias. Well, the phorias, I understand it. The foria would be more. This is when it's not. This is when it's latent. So when you initially see the patient, the corneal reflex will be completely normal, the eyes will look completely aligned. But you can bring out the misalignment when they cover one of their eyes. Is that right?
Okay, so let's say you have a left-sided esophoria. What do you expect to see in the cover-uncover test?
Well, you can tell me if I'm right, but from my understanding, I have a left-sided esophoria. So without covering my eyes look completely normal.
Yes.
If I cover my left eye, then my the tropia will emerge. So my left eye will look in towards my nose, and the clinician, if I'm correct so far, the clinician will be able to see this effect. One, if they use kind of a one-sided mirror. so that the or a one-sided device whereby the clinician can see the eye, but the patient can't see out of the device, or even if it's just their hand. Um, let me say, if you're using a device, then you should be able to see the eye look in towards the nose. But if you're just using your hand, then when you lift the hand off the eye, you should be able to see the eye recorrect
Mm,
back to normal. Is that correct?
yes. Except normally you
Aha.
wouldn't cover the left eye. You would cover the good eye or the right eye. I guess you wouldn't know which eye is good or not because it doesn't manifest without covering. So
Okay.
when you
Okay. So of course you wouldn't know, but if you did have an esophoria, then you should be able to, like, the effect will be elicited when you cover the good eye.
Yes. So when you cover the right eye in this case, and then
Mhm.
you remove the cover. Okay, so when the right eye is covered, the left eye doesn't change, right? Because it's aphoria. And the right eye was the good eye.
Mhm.
But when you remove the cover from the right eye, you should see that the eye shifts. The right eye shifts laterally.
Mm. The good eye shifts.
Hmm.
Wow. That is fascinating and confusing all at the same time.
Yeah.
But
I feel like we don't need to know this, but
no, we don't. This is ophthalmology resident or ophthalmology board level information. And so we probably have lost, our total of 0 listeners. I don't know if we can go into the negatives, if that's possible. But I would say let's regain back the attention of the listeners with one of your mnemonics. Did you have a mnemonic this week
okay.
that you wanted to share?
I showed this one to you yesterday. It is a mnemonic to remember some of the common complications of congenital infections. So there's a mnemonic for congenital infections that's classically taught in medical school, which is TORCHES. It stands for toxoplasma, rubella, CMV, herpes, and syphilis. Now, there are expansions of this acronym to include other viruses such as Zika virus or HIV, et cetera, et cetera. But the classical torches themselves have a classical set of complications. And my mnemonic for this is shitty. So the torches are shitty. SHITEE. S stands
I
for
read it.
sensory. Oh,
I read
sorry,
it
go
as
ahead.
shite. Torches are shite. That's what I reckon. That's what
Oh, well, I had 2 E's there that you might not have noticed, or maybe I added it
maybe
later on. So anyway,
I potentially have a strabismus.
I don't know if that, no, if you saw it, but you didn't register it, that's more of an attention thing, right?
Yeah, of course.
Which would be, it's not a form of neglect. I'm not sure. Actually, anyway, we digress.
Tell me about how the torches are shitty.
Yes. So the S is sensory neural hearing loss, which is most common with CMV and rubella. You can get it with the others, but it's rare in HSV. And in particular, sensory neural hearing loss with CMV, you should have a fairly high suspicion, even if they are a little older and still haven't presented with it, because it can have a late onset. CMV, by the way, is also the most common congenital infection next to GBS, which is Group B streptococcus. Okay,
C for common. That's I can remember. There's my mnemonic. C for common. Okay, keep going.
Yes. And then the next letter is H, and this can stand for many things. For instance, hepatosplenomegaly, which is enlargement of the spleen and liver. This is common in syphilis, rubella, and CMV. You can sometimes see it in toxoplasmosis and HSV. One of the mechanisms for hepatosplenomegaly could be thrombocytopenia, which is a decrease in the number of circulating platelets. It could also just be to infection of the liver itself. Another possible H would be heart defects, which is common in several of these, including rubella and syphilis. So rubella often causes a pulmonary artery stenosis or a patent ductus arteriosus. The next letter is I, IUGR, which stands for intrauterine growth restriction. This is common in most of these infections, mainly because it impairs the ability of the placenta to provide nutrients to the fetus. It could be due to vasoconstriction or inflammation of the blood vessels, but regardless, it dampens the growth rate of the fetus. T would be thrombocytopenia, which I mentioned is a decrease in the circulating platelets. And then E can be things like eye abnormalities. It can be edema or hydrops fetalis, which is a fatal complication of just having way too much fluid build up in the fetus, and then it leaks out into the tissues where it can no longer escape, and that can be often a cause of intrauterine death. Some of the eye abnormalities include chorioretinitis, which is fairly common, especially with toxoplasmosis and HSV, and also CMV. You can also have cataracts, which is a classic symptom of rubella infection. And then you can even get...
And my mnemonic for that is rubella. You rub your eyes. You rubella your eyes, and cataract. So
the mnemonic I learned for that, for the classic symptoms of rubella infection, congenital rubella infection, was I love ruby earrings. So the love represents a heart, so represents the congenital heart defects you can get with rubella infection. So that was PDA, patent ductus arteriosus, and pulmonary artery stenosis. The earrings represents sensory neural hearing loss. And then I stands for the eyes, right? So cataracts or retinopathy. Okay, so that's it. Torches are shitty.
I think, you know what, that is a great mnemonic. A lot to remember, but I think that mnemonic devices, I think for me are I think there's a reason why they're so pervasive within medicine. It's just because of the volume of information that we have to remember. Associating it with especially memorable things. Like I'm never going to forget that torches are shitty.
Hopefully. Hopefully not in at least remember it for 4 weeks.
Well, in the ideal sense, we're trying to remember this information. Well, I wanted to say forever, but I think only really applicable if you're going to be a generalist.
Or a pediatrician, in this case.
Of course. Well, what do you think? Does that round off our first episode here?
I think so. We're nearing an hour. Let me see. Yep. I think we did pretty well.
I think we did pretty well, but we also just could have retrograde amnesia.
Which is more common, or actually it's less common in Korsakoff syndrome. Usually in Korsakoff's you get anterograde.
Is it more common in some of the other congenital conditions?
Well, Korsakoff's
is less common.
Yeah, I don't know. Retrograde, surely that is... yeah, I don't know.
To be determined.
Yes. We haven't covered a lot of psych or neuro, I don't think, yet. At least the stuff that would affect memory like that.
Well, hold on to your scrubs, because it's coming. So to address our proverbial listener base, let's finish this off here. So that was Two Guys in Scrubs. If you want to support the podcast, leave us a like, a review wherever you listen to your podcasts. Thanks for listening, and we'll see you next time.
Jingle. Ba 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 ba.
Do-do-do-do-do.